Okay, good morning. Are you ready? We're going to talk today about classification in psychiatry. Really, what classification means is the arrangement into groups according to their observed similarities. There is a whole branch of science called Nosology. I don't know if I've got that slide. There we go. Branch of medical science dealing with classification of diseases from the Greek, as you can see there. Now, why is it important? So, classification is needed in psychiatry, well, in medicine full stop, for a number of reasons. To enable clinicians to communicate with one another about diagnoses. So certainly before the 80s, a psychiatrist in America talking about schizophrenia may not have been talking about the same thing with a psychiatrist in London. Also very useful to, patients and their families want to know what the diagnosis is, even though there are very often pitfalls into making a diagnosis. It's only after making a diagnosis can you then go on to suggest treatment and prognosis. And classification is important to consider clinical research and statistics. Psychiatry used to be practiced without classification. So before classification, certainly in the era of psychotherapy, psychotherapists were very much against the idea of diagnosis and classification. But where we are now, it is fundamental to psychiatry. And in this way, it's not any different to other branches of medicine. But there are big differences between psychiatry and medicine. So in medicine, if you're on a respiratory block or a gastro block, the diseases that you study, there is a good understanding of the etiology, the pathophysiology, and I don't know, minimal, maybe overstating it, that there's less overlap. Clearly if it's something like abdominal pain, there might be a lot of overlap. But in psychiatry, really, as psychiatrists, we need to concede that we haven't got a sophisticated understanding of the pathophysiology, the neurobiology of mental disorders, and there is a lot of overlap between the different disorders. So clearly on the right here, this is a tibial fracture, but the distress or the anguish that's evident in this young woman, could have a whole number of causes. And this is back to pathophysiology. So in medicine, we can talk about bacterial pneumonia. So there is a very good understanding of the pathogenesis. This man who you might consider to be suspicious and hiding away, and it's a little bit less clear what's going on. In medicine, in other branches of medicine, the diagnosis is made by the pathology. So the example I gave was bacterial pneumonia. In psychiatry, the diagnosis is made by symptom cluster. For example, depression is a cluster of 9 to 11 particular symptoms. Mental illness, in fact, is not an easy term to define, and they similarly describing somebody as mentally unwell. It was often mental illness was sometimes defined as the absence of mental wellness, which is somewhat circular. But this is taken from the American Psychiatric Association. It's very broad. Health conditions involving changes in emotion, thinking, or behaviour, or a combination. But not only that they're associated with distress and or problems in work, family, or social situations. So other concepts to consider in classification, I think you've heard of the biopsychosocial model. This has been quite prevalent since mid-70s or so. That there's a lot of debate still ongoing about a biomedical versus a social approach to diagnosis and classification. Just going back to this, so biomedical versus social. I think we were talking earlier today about many people feeling lonely. Should that be the more correct way of describing someone's suffering, or should we say that they're depressed and anxious? So that there is a tension between the two. The diagnosis has a specific meaning in ischemic heart disease because the pathophysiology is well understood. So in psychiatry, the lack of clear disease categories in a medical sense has led to the use of the more general term disorder. So the definition of a psychiatric disorder is a clinically recognisable set of symptoms or behaviour associated in most cases with distress and with interference in personal function. So correctly, we would not say that a patient is depressed. We would say that we would diagnose them as suffering from a major depressive disorder. Another example might be a generalised anxiety disorder, and it's a collection of it's a symptom cluster. Okay. So there are a lot of criticisms of classification, and allocating patients to a diagnostic category. This is called the categorical approach to classification. The argument is that this distracts from an understanding of the patient's unique personal difficulties, and clearly, it's evident that it's somewhat reductionist to condense someone's whole experience down to 3 words: major depressive disorder or just depression. We are all, and our patients are all a lot more complicated than that. Another criticism, allocating a person to a diagnostic category is simply to label deviant behaviour as illness. Here we're into the sort of anti-psychiatry area. So, I'm not sure this is not a mainstream criticism. And then individuals do not fit neatly into available categories, and certainly what we see a lot of is clinicians just trying to squeeze people into particular categorical boxes, and then where do you put the anxious person who is low in mood and hearing voices? There is very often an overlap of categories. So getting a little bit philosophical here. This is a quote from Kierkegaard. Once you label me, you negate me. So when the individual must live up to the label, the self ceases to exist. And we genuinely see this. People who are given the diagnostic label of, for example, bipolar disorder, will then view all of their behaviours through that lens. If they wake up feeling flat, it's my bipolar disorder. And now if they're excited and lively, it's my bipolar disorder. So they become that label, and the self ceases. And then also what we very commonly see is that people change their behaviour to fit their assigned label. There are a whole host of criticisms of the diagnostic category personality disorder. Many people are given that diagnosis too lightly, and what we not uncommonly see is that once people have been assigned that label, their behaviour will quite abruptly change to fit that diagnostic label. And then of course there is the stigma associated with having a psychiatric diagnosis. And as we were talking about this morning, psychiatric diagnoses are very sticky. Once that they've been assigned, it's very difficult. It's very difficult. Sometimes impossible to lose that particular label. So there are different classification systems. Well, two main classification systems. So there's the ICD. Just this year, there's been an update to ICD-11. This is published by the World Health Organization and is freely available to download. It's broadly similar to the DSM, the Diagnostic and Statistical Manual. That is published by the American Psychiatric Association, and it is a book that they sell, and it's an important part of their revenue stream. The last update was in 2013. A lot of criticism about the expansion of these. I think there are over 360 or so diagnostic categories, and many with lots of overlap. But certainly, as a medical student or a psychiatrist, these are the systems that you would need to have some familiarity with. So, a brief introduction there. If you have any questions or comments, please post them below.